my baby Jalonje. Tell my baby Jalonje. Yele 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 yele. Yele 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 yele. Baby, mtana sekasi, nigezi tupa mfunu tetana. Hello baby, mtana sekasi, nigezi tupa mfunu tetana.
Temang fige kasi zolak sungawon in Dombe yasekoli. Asangani kanang bamalana ngegalana. Then my friends told me I'm slow. I'm shying on high and I'm shying smile. I'm doing now oh yeah baba now take my hand. Was I in Kokalinda baba bolami nice pants and I'm singing like I sing funu tando lwap. Busy oh yeah jalelo mina. Angasu yang fabu yang keep. I may be crazy, don't mind me, but hey, I'll just straight it up. I'm banging Santa, so on Dele Tuesday. Come on now, follow my lead. Come on now, follow my lead.
Yes, it's time, this is all sako. No tinta manoni. Kizio ya mitali kufunga. Yes, it's fela mzima wako. It's all so good and easy. Ukole zanje inganyezi. Wakishia funga nani. Yes, it's fela mna.
She see cross, singing beat against time right down. Mina now sing that cross, I push us so hard, and time to be like great. We talk for hours and hours, I said that's a color, don't you start to live with us, I'll live too. Living guide in the taxi, the trouble is sexy, go to drive us all in the bed, great. And I'm singing like I sing for new time, no love. Busy, oh yeah, jalelo mina. I'm not so young, fabu young, see. I may be crazy, don't mind me, but hey, I'm just straight it up. I'm banging Santa, so on Dele Tuesday. Come on now, follow my lead. Come on now, follow my lead.
Yes, it's time, this is all sako. No tinta manoni. Kizio ya mitali kufunga. Yes, it's fela mzima wako. It's all so good and easy. Ukole zanje inganyezi. Wakishia funga nani. Yes, it's fela mna. Come on, be my baby, come on. 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 Come on, be my baby. Wanna give me more, baby, my baby. Wanna give me more, baby, my baby. Wanna give me more, baby, my baby. Wanna give me more. Tell my baby, Jalonje. Tell my baby, Jalonje. Yele 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 yele. Yele 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 yele. Come on, be my baby, Jalonje.
And if you believe with me, rise on your feet and let's sing together. Yo, 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 yo.
morning, everyone. I hope you were all dancing. I got some idea that some of the panelists were dancing. So good start to the day. Before I hand over to our chair for today, we were going to do another attempt at just doing a good Mexican wave and a big shout out to some of the satellites this morning. So first off, we're going to go to Zambia, to Pride. So Pride Zambia, if you can show us where you are, camera on. Can't see you. Where are they? No. Okay. Pride, we can't see you, so I'm going to move on. Maybe I can come back to you. See you. Community Health Alliance Uganda. Can you put your volume off so we can hear you? We can see you, we just can't hear you. Yay, now we can hear you. Wonderful. Great, wonderful. Next, we're going to go to South Africa, to Zoe Life. South Africa. Yeah. We're still at Community Health Alliance. Could we go to South Africa, Zoe Life? There, great.
From South Africa, let's go. And how?
Great, good to see you, South Africa. And then we're going to stay in South Africa, but we're going to East London. Imonti, where are you? Okay, no. Let's try Lesotho. Okay. Try go to Cape Town, Pata office, South Africa as well. And then we'll try some more tomorrow. Yeah, see you. Wonderful. Great. Great. Okay, so
I didn't do the video. The video still, you can still see us there. Yeah, but that live movie.
great. Okay, just before we hand over to the chair, just one last little housekeeping note. Many of you are sending wonderful, wonderful videos. We're unable to share them, you know, we're unable to share all of them because there's so many and they are amazing. So could I please just let you know, we're going to start posting all the videos when you're in the Summit Hub. If you go to session links and then you look right at the bottom, you'll see something called on-demand videos. So as the videos come in, we're going to start posting them there. And what you can do is maybe during tea time or during lunchtime or other times, if you could just play those videos in the background, that would be much, much appreciated. So all from us here, from the tech office, I'm going to hand you over to our chair for the session. So over to you, Faith Tipe. Thanks. Thanks, everyone.
Good welcome to the prime session of day 2 of the Partner Summit 2023. As a young person, I'm excited and honored to be your chair today, where we will be focusing on today's session titled Beyond Clinical Interventions, the Road to the Fourth 90. My name is Faith Tipe, as it has been said. I am currently a programs graduate trainee with the Global Network of Young People Living with HIV, popularly known as Y Plus Global. And in today's exciting session, which defines the critical fourth 90, also referred to as the fourth 95, which emphasizes the necessity of a holistic approach to HIV care for children and adolescents beyond clinical interventions. This session will explore the broader well-being of young individuals living with HIV, recognizing the profound impact of social, emotional, psychological factors of their lives. And we'll have different presenters in this session who will help us all to discover how we can accelerate progress towards achieving the fourth 90, ensuring that children and adolescents live fulfilling, healthy lives. And our first speaker or presenter will set the scene by unpicking the fourth 90 and sharing implementation strategies and World Health Organization recommendations in and around the fourth 95 for adolescents living with HIV. After that introduction to the topic, we'll hear a country example showcasing strategies used by the Ministry of Health in Eswatini to integrate the fourth 90 into service delivery. It will also include evidence from research studies in the Eastern and Southern Africa, which will also be presented, showcasing the power of adolescent and youth responsive services as accelerators for improved health outcomes. And lastly, we'll hear about the important role of young people in achieving the fourth 90. Might have to highlight that we'll listen to all the presentations for the sessions at the end of the session, and we'll have a time for our questions and discussions. You are welcome to write your questions on the question and answer box during any of the presentations, and our panel of speakers and facilitators will address the questions during the question and answer time. Our first presenter for today is Dr. Wole, and Dr. Wole is an adolescent HIV specialist with wide-ranging experience in program and policy areas, a trained medical doctor and with a master's degree in international public health. With over 10 years of progressive clinical and programmatic experience with government ministries, I will give this time now to Dr. Wole to give us his presentation.
Thank you so much, Faith, and what a pleasure it is to be here. Second time in a row. I was here at the PATA Summit the last time, and I am just so delighted to be here again and to see and connect with all of you. When I see videos from the different satellites, people joining in and being excited, it sort of juggles one's spirit, it's so great to be able to be here and to speak on this. So my name is Wole, as has been said. I'm with the World Health Organization in Geneva. But before joining WHO 5 years ago, I was a frontline health worker. My work was actually, training and mentoring doctors, nurses, community health workers in different countries. So when I am at PATA and I speak at sessions like this, I feel quite a bit of nostalgia, but also a sense of kinship with all of you, because I know firsthand what it is to be a health worker and the incredible sacrifices that health workers make, to get us to where we need to be. My slides are not showing yet, but if they are, yes. So that's it. Now, as working as a health worker, 7 years ago, one of the things that I noticed, having cared for patients, was that increasingly I found myself not just providing clinical services, but a lot of my time was now being spent moving away from providing those clinical services into what many of us call the other services, right? I found, without being a counselor, offering counseling, without being a psychologist, sort of offering this sort of, psychosocial type, advice and counseling and interventions to patients, to clients, and to care seekers. And that was where, I first of all saw that, beyond these clinical services, actually, there is quite a lot to be done outside of those clinical services to provide those clinical services. So my presentation today will be speaking on those other services. We call them different names. Today we'll be calling them the fourth 95, and I'll be speaking on unpacking them. Now, in doing that, I'll speak first about what we are familiar with. Many of us in the audience would know the 95, 95, 95. So that is the targets that have been set to enable the world end AIDS. And the first 95, as some of you may know, is about making sure that people get tested. So 95% of all people living with HIV know their status by getting tested. The second 95, of course, is now going further from testing. There is no point, getting tested without then following it up with treatment. So the second target on the second 95 is ensuring that 95% of those who know they are living with HIV then get ART, the antiretroviral treatment, which we know is life-saving, which then brings us to the third 95. Having been on that treatment, which we know is very effective and helps to prolong life and enhances healthy living, 95% of people are being now, the target is for them to be virally suppressed, having been on treatment. So this is quite in the realm of programming. We all know this 95, 95, 95. The next slide now speaks a bit to what we are less familiar with. In the last global AIDS strategy, the 95, 95, 95 was now expanded, which of course speaks to an understanding that we cannot just, focus on, we want to get people tested, get them on treatment, get them virally suppressed. There is a lot that goes around and beyond that to be able to achieve those targets. And that's where we have the 10, 10, 10, and 90. And what is that? It is that part of the target now includes less than 10% of countries having punitive criminalization or this sort of disruptive laws and policies that we know stops people really from getting care. The second 10 is about having less than 10% of people experiencing stigma and discrimination. There was a lot said about that in previous sessions. And then the final 10 is about having less than 10% experiencing gender inequality and violence. Now, these show that these laws, the policies, the stigma, the violence, we know stops people from getting care and can stop us from actually achieving the bottom line of the 95, 95, 95. The final, which is the 90, 10, 10, 10, 90, is ensuring that 90% of people living with HIV are linked to people-centered and integrated care, which essentially speaks about the fourth 95. On the next slide, we then look at the rationale. Why are we saying, you know, we need to look beyond, you know, those clinical interventions, the 95, 95, 95, towards more, you know, non-clinical holistic care. Well, the reason is not far-fetched. It is because we actually, despite a lot of progress that has been made since 2010, we still have a lot of unmet expectations, unmet targets. And if you look at the right of the screen, you would see, you know, the targets from not reach 90% of key populations, 90% of young women, providing, you know, condoms, PrEP, BMMC. All of these targets were not met in 2020, which speaks to the need for us to read between the lines, go beyond the superficiality of interventions, and begin to make the necessary adjustments for us to be able to enable good care for all people living with HIV. The next slide speaks to unpacking the fourth 95. I think there is a need, and you see that in my final slide, for us to make sure that we're very clear about what we're speaking about when we talk about the fourth 95. And I've just tried to, you know, in the circular diagram, show the key components of what enables the fourth 95. Certainly, we're speaking about the quality of care. So it isn't just about care, but making sure that quality care is provided, person-centered and peer-driven care. So young people, especially, need to be engaged and need to be, you know, at the center of their care, providing integrated packages. So not just HIV, but also all those other services that we know are very enhancing. So sexual and reproductive health services, mental health, and so on. And of course, making sure that we provide care for the priority populations, right? So always the easiest people, you know, it's easy to provide care to people who find it easy to access services. But we know that certain populations, due to those punitive laws and stigma, discrimination, find it difficult to access care, which makes it really important that we don't just look generally. We focus and have a laser focus on key priority populations as well. Next slide. The next slide speaks to, you know, the bottom line. The bottom line is that we want not just health, but well-being. We want adolescents to be able to have the support, the confidence, the resources, you know, to thrive and to realize, you know, their full potential and rights. This is a WHO framework which speaks to the different components and the different domains of well-being. And you can see it's not just about health, it's about connectedness. It's about positive values and contribution to society. It's agency and resilience and having that safe and supportive environment for adolescents to realize their full potential and their rights. Next slide. I'm being asked to speak a bit slower, so I'm going to even go even slower now. Now, so the case for the fourth 95 is made, right? Ensuring that we have not just 95, 95, 95, but 10, 10, 10. And this is just a slide, you know, speaking to the need to engage that fourth realm, and emphasizing that we cannot delink the 95, 95, 95 from the 10, 10, 10 that I've mentioned. It is impossible to also delist, you know, mental health and psychosocial well-being. It's really impossible to disconnect quality from care, and certainly we cannot detach health from the overall well-being of people. Next slide. On the next slide, I'm going to go very quickly through some of the WHO recommendations around the fourth 95, and you can go to the next slide, where I would speak about you know, this really important recommendation from 2016, I believe, on providing adolescent-friendly health services to ensure engagement and improve outcomes. So there's very clear evidence that we need to not just provide adolescent-friendly services, but also adolescent-responsive services. And we can see, from that diagram, the different health systems components, having adolescents at the center of those health systems. Next slide. I believe the next slide will speak to, mental health. That's as important as they come. In 2021, WHO, for the first time, really provided this strong recommendation, again, emphasized the need for the fourth 95, which says that psychosocial interventions should be provided to all adolescents living with HIV. Now, it is one thing to provide the HIV services that we need, but what this recommendation emphasizes is the need for integrated services, including psychosocial and mental health services. On the next slide, you would see a technical brief that further takes a deep dive into how countries and programs can integrate these psychosocial services. And I invite you to have a read. We can share those slides as well and resources after the summit. Next slide. On the next slide, another on peer-driven models. I'm sure there will be a lot spoken about this, but this is another policy brief on implementing a peer-focused and peer-driven models of care in our programs. Next slide. Yes, I think I have a couple more slides, and this again is something that's going to be shared, but you can see that there is a plethora of resources across the 95s that we can begin to use, right? We have the AIDS-free toolkit, which contains all of this, and also to say that all of these guidelines and resources are now in smart apps, so you can download them on your phones. Again, we can share these resources after the summit. Next slide. On my final slide, it's just a few thoughts for thinking on, right? And the first is about making sure that this fourth 95 conversation, is not seen as an afterthought, right? A lot of the time we speak about, the fourth estate of the realm, which is, the media. I think it's a bit similar. The fourth 95 adds quality. It adds accountability, ownership, and scrutiny for the overall quality and well-being of young people. When we think about fourth 95, we need to think as well of division of labor. We have to understand that we cannot do everything. There are different programs that are in charge of the different elements. So we need to be able to take the advantage of these institutions and expertise to deal with the different elements of the fourth 95. When we think fourth 95, let's think changes and adaptations, right? We have to make sure that we do things differently, try to act and not react, and make sure that we are constantly responding, right, to the ever-changing world and our different localities. When we think the fourth 95, let's think specifics, right? We must make sure that we do not cover, this the whole thing. It's not about doing everything. It's about picking, what is right and what is so important for the fourth 95, and making sure that we keep it specific about quality, engagement, and overall well-being. And then finally, what I said here in my final slide is what I said in the last PATA Summit. And I feel I should just sort of repeat it. I think it bears repeating. In moving towards 2030, we have to be moving in leaps and bounds now, right? There is no time to begin to think about, little progress here and there. We have to come together and begin to implement those interventions, including the fourth 95 interventions, in order for us to make not just progress, right, but far-reaching, milestone-achieving landmark attaining watersheds and breakthroughs. My final slide is a shout out to people I consider my constituency, health workers. The incredible work that you do, I know, and I think many of us know, is not spoken about enough. And I want to just make sure that I use my last slide to give a shout out to all of you health workers in all your diversity who support the HIV response in circumstances that are often very difficult. Thank you, and over to you, Shane.
Thank you, Dr. Ole, for leading us through that interesting session and laying the foundation for us all to understand what it means by the fourth 90 or the fourth 95, and highlighting what it will take for us to achieve it. And our next presentation will be by Nobuhle Mthethwa. Nobuhle Mthethwa is the public health specialist at the Eswatini National AIDS Program. Over to you, Nobuhle.
Okay, hello everyone. I'm Nobuhle Mthethwa from Eswatini. I'm the National Pediatrics ART Officer. So I'm here to present for you. If you can load my presentation, please. Okay, the fourth 90 in the national response, Eswatini, we know it's one of the countries that has put strategies in place to achieve the 95-95, and we've done that successfully in the past 2 years. Next slide, please. Eswatini, as I've said, has made progress towards the epidemic control. We've done the SHIMS 3 and we achieved 94, 97, 96 in the first 3 90s, and our life expectancy has actually increased to 59 years. New HIV infections and HIV-related deaths still occur due to the inequalities of barriers and access to healthcare, human rights, but it's very much significant in adolescents who have a new high number of new ART initiations. We're seeing new ART initiations amongst the adolescents, so that is why our focus, we need to focus on birth control and SRH services. The country's target for AIDS discrimination is less than 10%. We are actually sitting at 9.1 at this time, 13% for key populations, and it rises with internalized stigma. For self-stigma, I think that is 17%, so we can see that we still have a lot to do with self-stigma, which touches mental health, that I will talk more about. Then ART, we are using ART for both treatment and prevention. Many people that are living with HIV have maintained their physical health. They've achieved viral suppression and have improved quality of care. So now we need to go beyond their clinical care. The medical understanding of HIV has transformed from the fatal or emergency to that of chronic and manageable disease. As a country, we are actually even thinking about changing all the ART centers to label them as chronic care, so that we are able to integrate all the other services of chronic care. Viral suppression, however, should not be seen as the end goal for the response of HIV. There is more to life beyond clinical care. Next slide, please. As a country, we've managed to decrease new infections, as I've alluded with the SHIMS. We're able to see that we have actually achieved to decrease new infections, but there is that certain population that I talked about, that is adolescents. And I think as a country, and in most countries, we really need to focus on adolescents. Next slide. In a response for stigma and discrimination, we've done well on the first 390s, as we've said, new infections and curbing deaths, but there is still stigma and discrimination. And as I've highlighted, that mostly the stigma that is there, it's there in churches, it's there in schools, but also we need to deal with the self-stigma. So the Ministry of Health has actually worked closely with the multi-sector to address barriers and inequalities related to harmful traditional norms, stigma discrimination, GBV, gender inequality, discriminative and punitive laws, income poverty, legal and illiteracy, and unethical practices among service providers. So these are the issues that we are focusing on so that we are able to also achieve our road to the 490. Then the ministry also has worked with the following organization to engage communities in other sectors in addressing stigma and discrimination. The organization SNYP Plus, Eswatini, AICW, we have Nature, Congo, and UNAIDS that are currently working on stigma and discrimination. In 2023, we were able to conduct a stigma and index study, and a report is out already. I think that's where we took the statistics from that I alluded to before. Then we also have the arm of legal and human rights in the national response. The country has embraced the human rights principle of equality and non-discrimination. In collaboration with other sectors, the MOH, the Ministry of Health, increases efforts to apply rights-based approach and leverage community peer-based legal services to support those that are discriminated and to access and staying on the healthcare system. But we still want to say there are still issues to address issues of legal and human rights in key populations. Next slide, please. Now I was pressing my own button. There are also issues of socioeconomic barriers. We know for you to access healthcare services, you will need transport, you will need a lot of things that are beyond the treatment. You will also need your food, and so we need to address those things. So we have strategies that are in place that we've included and we're implementing. That is the targeted cash transfers, keeping girls in school, financial literacy, and economic empowerment. Even the caregiver groups, we're also like empowering them on financial literacy so that they're able to assist their children to maintain and access healthcare services. Then there's collaboration with other multi-sectoral actors with to expand social protection and other socio-economic interventions to reduce social economic vulnerability, to mainstream psychosocial support for PLHIV and other vulnerable groups at higher risk for acquiring HIV. So we have requested for social workers, of which the ministry gave us to attend to issues of pediatrics and adolescents. And I must say, through the GC6 Global Fund proposal, we were able to obtain 4 pediatric regional psychologists, and with the GC7 grant, we've actually lobbied and applied for more psychologists so that we cover all PLHIV, not only the pediatrics, because we are seeing, as we are still going to talk more about mental health, in the 490, mental health plays a big role for us to achieve the equality and quality of life of our adolescents. And then there's the community-led HIV response. Community-led organization, our CLSOs, are involved from problem identification phase, planning, up to the evaluation phase in programming. In particular, PLHIV, KPs, the AGYs, and ABUIM. Then when we're doing the National Strategic Plan this year, CBOs and CLSO were involved so that that also is put. Even when we're doing the Global Fund grant application process, they were of priority and they were able to put their inputs. Next slide, please. Addressing integration of services is another arm in the response. We need to do routine NCD screening with prevention treatment services in all HIV programs in an effective way to identify and treat PLA and with NCDs. We have integrated NCDs, especially in the HIV care, but we also have integrated SRH and HIV integration of services for adolescents so that they get one package, and we're also using the DREAMS platform for that. There's also peer-to-peer support in teen clubs. We've also integrated the Jandiri model so that our teens are taken care of. The psychosocial part also is taken care of, that is outside the treatment phase. We also have prevention and control of cervical cancer. We focus on women, and then the HPV DNA screening is also recommended for women aged 25 to 60 years. Also, the community-based HIV services. We promote continuum of care. We promote demand creation and utilization of services. Mental health, this one, it's quite big, especially in pediatrics and adolescents, because you may have, I think Dr. Wole has actually said that healthcare workers are doing a great job. They're giving the treatment, they're doing the counseling, but there are other barriers that are outside the clinical care. So we need another arm of force to help us with mental health. Hence, we are lobbying for more psychologists in the HIV space. So integration of health services in HIV SRH care, including screening, linkage, diagnosis, and management, is very important. Next slide, please. Social and behavioral challenges. We have challenges as much as the national response, we are able to address some of the issues, but we also have our own challenges in the response. Adherence still remains an issue, and we know that is a game changer for a good treatment plan. We also have a low rate of condom use, inadequate social support, especially in AYP or elderly. There's also drug fatigue among our adolescents and people living with HIV. So we really need to address that and do more counseling and support. Structural, we have limited availability of tailored fortnightly HIV interventions for different populations, access to services, stigma and discrimination, legal and human rights barriers, then the biological and physiological, the suboptimal immunological response to increase NCD and SRH. There's drug-to-drug interaction, and then you find that the client ends up having AHD, that is advanced HIV disease. So also with data, especially in the fortnightly, no defined targets or specific indicators for measuring the quality of life. And I think here, Dr. Wole, we would want actually TA as countries from WHO to actually maybe we start drafting the indicators for us to follow so that we can check them and evaluate them for the fortnightly in the different categories that we have actually mentioned in your presentation. Next slide, please. As much as we have actually alluded to or explained our challenges, we have achievements. We have a policy and a framework of the environment across multiple sectors in government, and we collaborate and support each other to implement the fortnightly strategies. But as we've said, it's still in a haphazard form. There is no clear way to track. If you can ask at what rate are we at, we will just put bits and pieces there. Integration of health services package supports the improvement of quality of life beyond viral suppression. Then income generating literacy, adherence, psychosocial support. There's also a client-centered care at implementation scale. So this model also works. Peer-to-peer driven models have training packages, and they are trained on HIV, SRH, mental health interventions to work with different stakeholders. Then the scale up of friendly health services for adolescents and key and vulnerable populations. So this is what we've achieved as a country, especially in the fortnightly. Next slide, please. I thank you.
Thank you, Nobuhle, for the inspiring presentation, highlighting the various strategies used in Eswatini to improve the quality of life for people living with HIV. And please remember, we will have the question and answer at the end of all our presentations. And now allow me to introduce the next two presenters who will speak before we open up for our question and answer. The third presentation will be given by Professor Elena Tosca. Professor Elona Tosca is an adolescent health researcher at the Center for Social Science Research at the University of Cape Town. And our final presentation is by Francis Nwanko. Francis Nwanko is a dedicated advocate actively engaged in various roles. He is a youth advocate for Y Plus Global and a member of the Youth Advisory Group for the Vibrant Young Voices Project. And we'll now give it up to our tech team to play the recorded presentations for Elona and Francis.
Thank you for having me today. My name is Elona Tosca, and I am a researcher at the University of Cape Town. Today, I'll share with you some data and evidence and reflections on how adolescent and youth responsive services can help us accelerate our progress towards improving multiple health outcomes for adolescents and young people living with HIV. We all are here to work together on improving not just individual outcomes like HIV related ones such as viral suppression, but overall quality of life amongst adolescents and young people living with HIV. Today, I will talk about 3 overall topics. First, some provider perspectives on adolescent service provision since COVID-19 started in South Africa. Second, some analysis on how adolescent responsive services can improve different types of outcomes for adolescents. And third, what kinds of models have worked in helping us provide adolescent responsive services? This adds to what Wale presented earlier. First, some data from South Africa. I'm delighted to be here to support us all think, particularly those of you who are at the front line of service provision. This is work led by Dr. Jane Kelly at the University of Cape Town with a big team in the Eastern Cape of South Africa who are listening online. They talk to nurses in many different facilities about their experiences providing HIV and sexual and reproductive health services since the pandemic started. I'll talk about 2 big areas that emerged. The first is that the service provision was very affected through starting since the start of the pandemic, but in some ways it still continues. And this was not just HIV services, but also family planning. Partly, services were not able to be offered regularly, and this resulted in young people not showing up. And when they did show up, they were not able to receive the additional services like mental health support. And as a result, we saw increases in defaulting in young people living with HIV. But when young mothers and young women specifically couldn't access contraception, increases in pregnancy. It also highlighted experiences that you all have in providing services to adolescents. Adolescents, particularly the younger ones and the ones transitioning, are really, they're wonderful. But they're also having a hard time adjusting sometimes to being a young person. So as adults providing services for them, we're often caught between empathy, understanding that it's hard to be an adolescent, but also really telling them how they should do things because we know, because we do, we have lived through life and we are adults. And this tension between, adolescents have attitude and they don't listen, but we really want to help them. We should always remember that as we provide services. And the nurses and the healthcare providers in the Eastern Cape really felt that. But you still show up, many of you, and you provide services to adolescents that are responsive and really improve multiple outcomes. So let's look at some data from a few different parts of our region. First, data from South Africa. When we talk to about 1,000 adolescents living with HIV in the Eastern Cape, we see that those who had access to facilities where medication was stocked, where staff had enough time to spend with them, and they had someone to go to the facility with them, particularly the younger adolescents. They had enough money to get to the facility, and they felt that they were not being shouted at or judged. The staff was kind. Those that received all of those 5 provisions in the clinic, and it was just over half of them in that situation, they were much more likely to be fully retained in care. You can see the yellow bar over here, nearly 70% were stayed in care. They didn't miss appointments and they did adhere to medication. This also worked for adolescent girls and young women living with HIV, because we know even though we've made huge gains in HIV prevention, we actually still have a large cohort of young women living with HIV that we want to support. So adolescent girls and young women in South Africa who said that they could get to the facility safely and at no cost and receive respectful and kind services by the staff there had improvements not just in one outcome, adherence, but also in TB-related symptoms and in viral suppression, in addition to having no treatment, less treatment interruptions, and better clinic attendance. But they were also quite wary of going to the clinic. They were worried that nurses would judge them, so they were scared. However, we see that this is not the case all the time, and quite a lot of our adolescents received really positive care when they were accessing HIV and SRH services. In this table, you'll see in the line surrounded by the orange box is that adolescent girls and young women who received respectful care and were listened to had improvements in hormonal contraception, condom use, and dual protection. And this was even though there were repeated pregnancies that were happening in the sample. And when combined with being offered two methods, they were much more likely to use dual protection. And you can see this in this graph. Adolescent girls and young women who did not have positive clinic experiences were not offered two methods and did not have good condom negotiation skills with their partner. Only about 5% of them used dual protection, but it went up to over 80% when they had condom negotiation skills, when they were treated respectfully at the facility, and they were offered more than one method. When we see going beyond just HIV and pregnancy prevention, the outcome at the bottom, when we combine youth-friendly services with supporting young women to stay in school during pregnancy, support with childcare when they have children, and building their confidence, which is something that peer-based models do really well, we see improvements not only in pregnancy and HIV prevention, but also in school return and school progression, which are things that young people really care about. And this is also data from South Africa, analysis by Dr. Janina Joachim at the University of Oxford and Professor Lucy Kluwer. So my last part is to get us thinking, okay, well, great, we should have adolescent and youth-friendly services because they clearly make a difference, not just to HIV outcomes, but also other elements that young people care about, like schooling and contraception and not having repeated pregnancies. So what has worked in the past? There's a lot of models that we are trying, but we know that when we combine healthcare worker training and support with facility improvements and community-based programs, that is much better. Those are programs, multi-component programs that have shown to work. When we just do things that are only in the healthcare worker training and facility adjustment, that does not always work. So thinking about just keeping things in a clinic is not good enough. And this is where clinic community collaborations that you at PATA do and in different countries and settings really makes a difference. And we should be cautious about thinking about setting up standalone youth centers only, because we really need to think about it as a multi-component approach. One example from Ethiopia is the Health Extension Program. And this is community health workers who delivered a structured program to families and adolescent girls who were in those households that graduated the Health Extension Program did much better in reducing child early pregnancy, delaying child marriage, and having better education outcomes. You can see these three. They were more able to stay in school and did better in literacy and numeracy. We have heard lots about the Young Mentor Moms and Jandiri, but they really are a model to celebrate working together in a clinic community collaboration approach. And really, it's powerful to see the data here, which is the number, it's a viral load cascade looking at female clients who registered in 2023. This was data from the middle of the year, and how many stayed with viral suppression, which is really impressive. And looking at these two other indicators when compared to national data, much stronger early infant detection rates and much lower vertical transmission rates. We've also done some work, I hope colleagues in Lesotho are listening in, but also in other countries with young people who are part of the of ACPAF's Committee for African Youth Advisors in designing some art-based tools that can help with difficult conversations. This would always have to be complemented by other components, but this is focused on U=U messaging, which is very powerful and can really make a difference in our work. These are available for sharing if you reach out to the team, and they're being used already in Kenya, in Lesotho, and a few other countries to simulate conversations around U=U in the context of early motherhood, in context of new relationships, and also in the context of young men who have sex with men. And lastly, an example from Zambia, from the KCIA PATA collaboration with our teams at the University of Cape Town and Stellenbosch University, focusing on how can we support healthcare providers really screen and link and support young women living with HIV, but also young men in the big picture in accessing violence prevention, but also post-violence care services. This is a tool that the team has put together that you'll hear a bit more about. So to summarize, we have good evidence that there are these key components and approaches to enhance adolescent responsive care: training on topics, including educational meetings, strong supervision and quality control support, working with peer-based models to extend and strengthen what we can do, engage with community healthcare workers, and really think about having leaders and mentors and role models. And really, if we do these, if we bring young people to facilities, if we provide responsive and respectful care, if we support through peers, caregivers, but also partners, sexual, romantic, parenting partners, and also support these caregivers to provide adolescents with parenting care that they need, but not forget about the economic support that families need, will be able to make the biggest difference in improving the quality of life for adolescents and young people living with HIV. Thank you very much for listening.
Hi, everyone. Good morning, good afternoon, good evening from wherever you are joining. My name is Francis Kasmia Wankwo, a member of the Youth Advisory Group of for the VYV Consortium for Y+ Global, which is a consortium with partners from PATA, Y+ Global, and SICABA. And I'll be taking us through a session titled Youth as Change Makers, Improving the Life of People Living with HIV. Now, we're asking the question, what have we learned thus far about the FORT95? The previous presenters have helped us unpack the FORT95 and to highlight interventions that are essential in achieving health and well-being of young people living with HIV. And we've also learned that we cannot delist mental health and psychosocial well-being. We've also learned that we cannot disconnect quality from care, because the both of them have to come together and have to go together. We also have come to understand that we cannot detach health from well-being, because it is health is also a part of someone's well-being, both the mental, the physical, and social well-being of that person. And we've been provided with evidence on the power of adolescent and young people responsive services in the road to achieving in the FORT95 for young people. Okay, now we are going to have a little bit of a short clip. So that will be for my presentation, where I'll be providing an example which will highlight the pivotal role of young people in achieving the FORT95.
My name is Wankwo Francis Kasmia. I'm a member of the Youth Advisory Group for Y+ Global.
Today, I'll be having a conversation with Mr. John Bosco Nkemdili, a mentor.
Why do you think it is important to engage young people in the health care system?
Most of my staff are young people, and young people are passionate about what they do and are highly innovative. So let me use an example of one pilot project we commenced from last year, September, Ya Naija, Youthful, Alive and Healthy Nigeria. It's all about creating awareness for HIV self-test and equally driving to increase HIV testing, especially among young people. And the people that are driving the process are mainly young people because they are taking advantage of the social media, which is technology-driven approach to intervention. So, and we are getting a wider reach and coverage of our young people and the rest of the population getting reached with required the correct message of HIV and other diseases that we also trying to bring control. Our work is mainly field work. They do it almost 24/7. When you call them, they're able to answer you. So the feedback in working with young people is very, very encouraging. It's very hard for one to now see a young one that doesn't have a phone.
Yes.
So
Especially those big phones.
So we see them as our, maybe should I call them our gateway to get into the other population within the society. Exactly. So we hold them in a high esteem. If we are doing our work plan, we must ensure that we have a good number of these young ones.
Yes.
Because they are the ones that will take this message, analyze it, and see how it's beneficial to them, and even discuss it wherever they go. So everything about this work revolves around the young ones. So they are very key, and from experience, there's never been a program that we've run using these young ones that we failed. Maybe we may have one or two, but at times the result is highly rated.
Okay.
So working with them is good for us here in the agency. You must make provision for young ones, unless you don't want to succeed in whatever intervention you are doing, especially in the field of public health and HIV and AIDS that we do.
That has been a very enlightening and engaging conversation. Engaging young people is all about sustainability. If you want to sustain a quality healthcare system, a healthcare process, you need to start engaging young people at all levels and in the process. I believe that going forward, we are going to have a better and an AIDS-free global space and a healthcare system that is more inclusive, more engaging, and more sustainable using young people. Thank you very much.
I believe we enjoyed following up with that very short clip that has to do with an interview session with the Executive Director of the Anambra State AIDS Control Agency here in Nigeria. There are key takeouts from both the video and from other presentations we've been having so far. And the interview we just watched highlights how youth are key in promoting and advocating for quality of life, especially for their peers living with HIV. We've seen a lot of scenario here in the state, and in some states I've been to in Nigeria. We see where young people are the one driving and speaking up, and even defending the rights of fellow young people, and of course, people also living with HIV. So it's a very good thing and a very beautiful sight to behold. So and of course, all the interventions that have been mentioned by the previous presenters here on this call has been very, very key, and they have portrayed the need in order to achieve the fourth 95 rather, in order to achieve the fourth 95. They've mentioned how young people are very key First, we talk about for a successful adolescent-friendly health services, we need the input and, of course, the feedback of our youth in providing these services if we want to provide quality adolescent-friendly health services. For peer-driven models, again, at that point, we also need young people. We also need their insight. We also need their voices to be captured in the process if we want it to be very inclusive and very engaging. And integrating mental health interventions in HIV services. At this point, we also need the input, also the participation and feedback from our youth. So if you want to get the quality service, if you want to achieve your goal, of course, you need them at the level where you're also trying to plan this process. You also need them to have their voices captured in while designing this program. You also need the young people, the youth, to also participate in the process. And you also need feedback, which has to do with evaluation. You have to checkmate how well have your services been. And of course, if the youth are not pleased with the services, the quality of services that you're providing, of course, it is not, it's obviously not young people's friendly. And that such program tends not to outlive the taste of time, of course. And also young people, we are innovative. I know I am. And I know a lot of beautiful, wonderful, brilliant young people I've also met that are very much innovative, people who I still look up to learn on how to be very strategic and how to be very creative in whatever I'm doing. We are risk takers. As young people, we tend to take up the most difficult parts of whatever we are doing. Young people can go to places that seem difficult for people, just like we could also see in the photograph that was attached to in the slide. You could see young people going to different places and to places that seem unreachable. You see young people going there to carry out whatever services that is needed to be carried out in those hard to reach areas. And of course, we are advocates. The domestication of the anti-stigma law in the country has been something that young people have been championing in different states and regions of Nigeria, where young people are advocating for domesticating the Anti-Stigma and Discriminatory Act against people living with HIV. Young people have been at the forefront at various states and regions, requesting, calling on the lawmakers to domesticate the act into the state, so it becomes a law and binding too at the various state levels. So young people are very, very strategic in such engagement. And also we are movement builders. Of course, young people does a whole lot of movement building. It is very difficult to see a young person doing something, carrying out an activity alone. He or she or they would always engage their peers. We are very good at engaging our peers in whatever we do, because that's also what spices up the process. That's what spices up the activity. The more young people you see together doing something, the more possibility for greater achievement. So young people have this spirit of teamwork and of course movement building. And we cannot overemphasize the fact that in order to achieve quality of life for people living with HIV, that young people needs to be meaningfully, and not just meaningfully, we need to be ethically engaged in all levels of planning, implementation of interventions. And of course, not just the planning and implementation, we also need to be there in the evaluation, in the review of such implementations. We need to be there at all levels of these activities in the HIV and public health sector. So, and of course, if you also go back to the video, you also see where the executive director talked about sustainability. So for you to also sustain whatever program you want to do or whatever program you're doing, young people needs to be very much carried. They need to be the drivers, not just carried along. They need to be the drivers of the process, because we make use of a whole lot of spaces. The internet is our world. We basically live our lives in the internet, of course. So, and you know, the internet is somewhere that you pass through to get whatever you want, and the media is an avenue for you to reach a very wider range of people. So for whatever you're doing to reach a very wider range, young people needs to be there. For you to sustain the process, they also need to be there, because like I also say, we are not the leaders of tomorrow. We are the leaders of today. And we want to see the country, the Africa that was promised to us by our leaders, by our parents, by our elders, and all those who have also struggled in the fight against HIV and against stigma and discrimination. So I think and I hope I am going to be getting some feedbacks, but of course, because we need also feedback for us to do better, to get more insight and clarity. So I hope I am going to get some questions and probably some contents on contributions during the questions and answer session. And I will be here to answer whatever questions that you will be bringing to provide more clarity. Once again, I am Francis Kasmir Wankwo, the member of the Youth Advisory Group for the VYV Consortium. Thank you for your time. In Igbo, we say Dalo. In Hausa, we say Nabodi. And in Yoruba, we say Eshe, thank you, and hope to see you in the Q&A session. Bye for now.
Thanks for that wonderful presentation, and thank you to all the panelists for the insightful presentations. It is very clear from listening to you all that in order to improve quality of life, we need to expand the focus and strategies beyond clinical interventions, that is in quotes, and that it is vital to consider and address the holistic health needs of people living with HIV, that is all encompassing of physical, emotional, and mental, so that the quality of life is optimized now and in the long term. And before we take a look at the questions coming in from the audience, I've seen that we have quite a number of questions, and some of our panelists have already responded to some. I'd like to start the discussion with a few questions from my side. And just a reminder to the participants to please use or type in your questions in the question and answer box and your general comments in the chat box. And once again, thank you so much to all the speakers. The presentations have been most informative, and we will now be going into the question and answer portion of the session, and would like to ask you to keep your answers brief and to the point and respect the time that is available to us. And I'll start with Francis. One of the recommendations that was highlighted in the presentations regarding improved quality of life was health service integration. And in your experience, could you tell us more about how integrating services, especially mental health support, contributes towards the fourth 90 for adolescents and young people living with HIV?
Right. So perhaps this is for anyone who wants to take the question. So I'm just gonna probably start. by saying, I think it's a great question. So the question is about how do we ensure that integrated services contribute to the fourth 90? I think that perhaps it's more a bit of a nuanced question as well, because it's about contributing to the fourth 90, but it's also about contributing, to the end goal of quality care, but also overall well-being. I think Nobule and Ilona, mentioned that very critically. So my short response to that would be, ensuring that in our discussions, with programs as we develop our strategic documents and the national strategic plans, this idea of integration moves away from what it currently is. It's currently, like an idea. It's floating sort of in the air. We need to make it concrete and ensure that it is actually, put into our plans, but then also very critically funded as well, so that we can, get those results that we need.
Thank you, Dr. Ole. I think I'm going to come back to you again. Measuring health-related quality of life is often mentioned as a difficulty, and there is a lack of data and specific indicators to measure health outcomes and quality of life of people living with HIV. Would like to know what has been approaches that have been recommended either by the World Health Organization or any evidence-based research to monitor and measure quality of life.
Again, thanks, Faith, for that question. Just to keep it brief, I would say that in looking at the approaches, we have to, think a bit differently, right? So normally we talk about the end justifying the means, but now we need to sort of flip it over. When we talk about quality of life and those measuring indicators, the means justifies the end, right? So we have to look at the different processes, okay? One approach that has taken, that has had a lot of traction and which makes a lot of sense is an approach called community-led monitoring. So this is an approach that ensures that, people are at the center of tracking and monitoring interventions that are meant for them, right? So if I am the one receiving services, that my idea and my perception of quality, trumps, anyone, I'm sure. So I think it's really important that this idea of community-led monitoring and putting people at the center of driving and measuring their own care and what quality means to them is really important.
Thank you, Dr. Ole. I'll move on to Elona. Elona, addressing stigma and discrimination in health systems, communities, and policies, as well as self-stigma, is at the forefront of empowering individuals with HIV and supporting their well-being. As this summit is focused on the face of care, what do you think are practical actions that health providers can do to address stigma and discrimination in health facilities in their communities?
I think for me, and I've been thinking about this for a long time, and I'm a cheerleader of anyone who spends any time with patients because it is a really hard job, is to think about, and this is maybe a bit hard to do every day, but is to think of one's role as two parts. The first is the bearer of technical knowledge. A person is in front of you and is trying to actually understand their medication. They will not really understand a third of what you say, maybe 2/3, and you want them to take forward the actions that are linked to actually something very technical. But the second, and I think this is why the fourth 95 is so vague in some ways, is that you're also trying to set them up as a human to be the best version of themselves with all the difficulties that they have in their lives. So there, it's less about telling them what to do and actually just being there and understanding that if they're having unprotected sex, if they're showing up late for appointments or missing them or being risk takers, which is quite common with adolescents, they're not doing that to be evil to the provider. And I think that takes a bit of work to shift because we have very tight timelines, but it is a bit around that understanding that the technical part can go so far and the soft part of what we do with people and with ourselves, it has a different role. And I know that's quite vague, Faith, but it is obviously the way we get it is by having peer supporters who remind us of this, by having training for providers with actual skills on how to have difficult conversations, and also reminders that we were all a bit lost, confused, risk takers, annoying, but also really cool when we were young. So just keeping all of that in mind, because we'll get better results for all of us. Over.
Thank you, Elona. And now over to Nobuhle. Your presentation mentioned various strategies used by the Ministry of Health and other sectors towards ensuring the fortnightly for people living with HIV. Could you elaborate more on some specific examples or models that you think other countries could learn from? And that would be key for improving quality of life, especially for children, adolescents, and young people. And keep it brief. Thank you. You're speaking on mute, Nobuhle.
Thank you, Faith. I think that's a beautiful question for us to respond that one the strategies that we have to prioritize is putting the youth first, let them lead. We must have frameworks that support the transformation for youth that are in a position to be tracked and evaluated. We need to improve our DSD models for the youth and their caregivers to access healthcare services. We need to empower and invest in the youth and let them be agents of change. Peer-to-peer support, we've seen that model working very well. Most countries need to maintain it and actually sustain it with budgets. And then we need to strengthen mental health as countries. I know we have structures that are there and there, but we need to put a budget and plan well for mental health. Currently, my country has only one hospital for mental health, but we know the need. So we really need to focus on mental health. Thank you, Faith.
Thank you, Nobuhle. And Francis, we have a question from one of the attendants. They are asking, do you feel that the youth get enough support from NGOs?
Okay, thank you very much for that question. I would say that the youth currently are gradually coming into space. Prior now, we do not have enough support from the non-governmental space. And we always have challenges of a lot of times they say, oh, we're young people, the capacity is not there. We also get feedbacks like youth can be very radical at times. And so most of the times the donors and some of the non-governmental organizations are a bit skeptical in engaging young people because of probably little flaws we have. So, but I think that is why we say there is room for growth. And of course, currently the global space, everybody, even within the country, Nigeria, we are also seeing young people taking up spaces and doing exceptionally well. So I would say it's a 50-50 something. And currently there are some changes, and I believe it is something that will also improve over time. Thank you.
Thank you so much, Francis. Now over to all our presenters. You can engage with the question and answer section to answer any questions that we haven't answered. And I see some of the questions in our chat boxes, though you had asked that the chat boxes is kept for general comments. You can always go over them to see if there are any questions that you can address. Yes, thank you very much for your time and the answers that you have provided to the questions that have been asked so far. A special thank you to you all, our incredible partner, and to all the health providers and young people, and of course to everyone listening. And from me, it is a goodbye. Have a good day. Thank you.
Thank you. Bye-bye.
Thanks, everyone.
Thanks, everyone.